Good morning, everyone. Welcome to this discussion on ventricular septal defect. This is important because if you are looking at infant mortality due to congenital heart disease, one of the common conditions which is responsible for that is a large ventricular septal defect. So identifying a ventricular septal defect and getting it operated in time is an important part of our effort to reduce infant mortality from congenital heart disease. We could start by looking at what is a ventricular septal defect. You know that it is a developmental defect of the ventricular septum resulting in a communication between the two ventricles. At this point, it's worth recalling that the interventricular septum is formed by the fusion of three different septums. The membranous septum born out of the endocardial cushions, the outflow septum, which is a part of the aorticopulmonary septum that grows down in, and the muscular septum from the primitive interventricular septum. Therefore, defects in the ventricular septum are related to these three structures. If you look at this promotional diagram of a device, you can see the basic problem in a VSD. Watch here. This is the ventricular septum. Here is the left ventricle. Here is the right ventricle. And you are finding a big defect in the muscular part of the septum. Look at the mitral valve here, the tricuspid valve here. And this defect results in oxygenated blood moving from the left ventricle to the right ventricle and increasing the flow into the pulmonary artery. The location of the defect has a lot to do with the prognosis of the defect. The view that I have shown here, imagine that you have a heart on the table, you have chopped off the anterior wall, so you have the right atrium here and the right ventricle here. This is the tricuspid valve. Why we tend to classify VSDs this way is because the surgeon does an atriotomy and looks at the ventricular septum through the tricuspid valve. So we are trying to simulate that appearance in this cartoon. If you look at the landmarks here, this is the tricuspid valve. Here is the pulmonary valve. The aortic valve is not shown in the picture. This is the apex. Here is the pulmonary artery. Here is the aorta. This is the pulmonary valve. Remember, the right ventricle has an infundibulum, which is marked off from the cavity of the right ventricle by a crista supraventricularis. This is the crista. So any defect above the crista, below the pulmonary valve, would be called a subpulmonary defect or a supracristal defect. Subpulmonary or supracristal. So the relationship is to the pulmonary valve. The surgeon, when he opens the pulmonary artery, he can see this through the pulmonary valve and he can close it without actually opening the heart, opening the ventricle. This is less common. It accounts for only about 5 to 7% of isolated VSDs. But the overwhelming number of VSDs that you see, 70%, is perimembranous. A perimembranous defect it is necessarily below the crista, it is infracristal. The aortic valve is not shown here, but it is an aortic valve and the continuity between the aortic valve and the tricuspid valve in its roof. So a perimembranous defect is at the junction of the three areas of septum that we referred to in its embryogenesis. And it's also called paramembranous less commonly. The most common word is perimembranous. Some would call it conoventricular. This is otherwise subaortic. It is the commonest type of VSD. The next one that you would find is an inlet type of VSD. This inlet VSD is right under the septal leaflet of the tricuspid valve. So in an echo, we will demonstrate what is an inlet VSD like, and standard appearance of this is in Down syndrome. It's a large inlet VSD along with a primum ASD which constitute a complete AV canal. This is only about 5%. 20% of VSDs are muscular. They are lower down, as you can see here in the muscular part of the septum. We may further classify it as apical when it is towards the apex. We may classify it as anterior, posterior, mid-muscular, depending on the actual location. Looking at some epidemiology, it is the commonest congenital heart disease if you don't consider bicuspid aortic valve and constitute 20 to 30% of all congenital heart defects. And the prevalence varies from 3 to 5 per thousand live births. Remember, our standard figure for the incidence of congenital heart disease is 8 per thousand live births. So if 20 to 30% is VSD, you are looking at a number of 3 to 5 per thousand live births. But if you are looking at the echo detected small muscular VSDs these days, you will find a far higher prevalence, maybe as much as 50 per thousand live births. In our figure of 3 to 5, we are looking at the more significant ones which are likely to be picked up with a murmur. What does a VSD do? What a VSD does to the heart and circulation is decided by the size of the defect, because imagine the left ventricle and the VSD. If the VSD is as big as the diameter of the aortic annulus, the LV can as well eject into the RV as it can eject into the aorta. That is why we take the aortic annulus diameter as a benchmark measurement for calling a VSD large or otherwise. So the size of the defect is an important determinant of its hemodynamic outcome. The pulmonary vascular resistance is an important determinant because the baby is born with a fetal pulmonary vascular resistance, and this rapidly declines and reaches adult levels by about 6 weeks. So a VSD under ordinary circumstances in a term baby hardly shunts in the newborn. With every passing week, the shunt gets established. So no wonder a VSD is picked up by auscultation more often in a later visit to the clinic rather than a murmur in the neonatal ICU. The systemic vascular resistance is also a determinant of the hemodynamics and the left to right shunt. After all, if the aortic pressure is high and the systemic vascular resistance is high, the VSD will shunt more. And if there are associated defects, imagine aortic stenosis. LV pressure tends to be high, and it equilibrates with the right ventricle by pumping through a large VSD. So the flow across a VSD is increased by aortic stenosis. If there is RVOT obstruction, on the other hand, it discourages the LV from shunting into RV because now the resistance in the RV circuit has gone up. If there is any additional shunt, of course, the patient will have a greater brunt to bear. Like if there is a large PDA as well as a VSD, that baby will suffer greater amount of heart failure than a baby with a VSD alone. So these are some of the determinants of what happens to a baby with a VSD. So what does a large VSD do? There is a left to right shunt. This evolves as the pulmonary vascular resistance is dropping. So you will feel the brunt of the shunt by 2 to 3 months. By 6 weeks, it is established. By 2 to 3 months, the baby ordinarily is in manifest heart failure. Increased pulmonary blood flow, of course, that is the reason for all this. In the heart, as picked up on echo, the left ventricle as well as the left atrium are enlarged. And if you were to measure the pressures in the heart in a catheter lab, the PA pressures in systole would be systemic because if the VSD is large, RV and LV pressures are same, and RV systolic pressure is what the PA systolic pressure would be. But the diastolic pressures in the PA continue to be less than systemic. If you have it's a newborn, sorry, a 3-month-old baby, you have a blood pressure like 95 by 60. That 60 is the diastolic pressure. The PA pressure will be like 95 in systole and maybe 35 or 40 in diastole. It's elevated, but less than systemic. as long as the shunt is large. The cardiac output tends to drop. When the baby is in heart failure, the cardiac output tends to drop. And as I just referred, the pulmonary vascular resistance is invariably elevated, but it's below inoperable levels. We consider 6 Wood units as the cutoff point for operability. Less than 6 Wood units is what you would consider operable. But the point is the pulmonary vascular resistance is necessarily elevated in a large VSD to some extent. Now, let us crystallize some of these comments. When you say that a VSD is small or restrictive, the diameter of the defect is less than a third the size of the aortic office. RV and PA pressures will be normal. Left to right shunt, we measure in terms of the pulmonary blood flow as against the systemic blood flow. It's less than 1.5:1. If we look at the LA and LV in the echo, they are normal sized. That's all. A small VSD, less than a third of the aortic orifice size, less than 1.5:1 pulmonary systemic flow ratio, normal LA and LV. If we look at a moderate VSD, it's obviously larger than this, but less than the size of the aortic orifice in any case. And the RVPA pressure ratio will be less than 2/3 of the systemic pressure. It's elevated, but less than 2/3 of the systemic pressure. And the left to right shunt, of course, is more than 1.5:1. And LA and LV are dilated. It's a large VSD, restrictive. We already defined it that the diameter of the defect is equal to or more than the size of the aortic orifice. The pressures in the PA and RV in systole are systemic. And the degree of left to right shunt depends on the pulmonary vascular resistance and is established by 2 to 3 months, the full brunt. LA and LV are dilated when the pulmonary vascular resistance is normal or mildly elevated. One important question and an area around which a lot of I would say superstition hangs is the natural history relating to spontaneous closure. Rate of spontaneous closure depends on the size and location of the defect. We can't say that any defect has a chance of spontaneous closure. There are a number of variables there. To begin with, spontaneous closure is very unlikely in a large VSD. One. Second, certain types of defects, an inlet VSD, a malaligned VSD, and also a subpulmonic VSD. I have not mentioned it in the slide, but a subpulmonic VSD does not close spontaneously. An inlet VSD, a malaligned VSD, and a subpulmonic VSD, they do not close spontaneously. On the other hand, muscular VSDs are the ones most likely to close spontaneously. Unless they are very large, they have an excellent chance of decrease in size at least in 25% of the patients and complete disappearance in a much larger number if it's a small VSD. So a small VSD, especially if muscular, has a more than 50% chance of spontaneous closure by 5 years of age and more than 80% chance by adolescence. This is the good part of it, the ones that close and the ones that do not close. But what happens to the babies with the real large VSDs? About 10% of them die in the first year, primarily because of congestive heart failure, quite often with a superadded pneumonia. A small percentage, not very small, 13% up to, may develop infundibular stenosis. This was not present before, but over a period of time it develops, may become manifest by 6 or 7 months. So a baby that you were treating for heart failure with a large perimembranous VSD, the heart failure disappears and you hear a louder murmur, and this is called the Gasol phenomenon, acquired infundibular stenosis in a large VSD. Aortic regurgitation may occur in 6%. This is because, remember, a perimembranous VSD is subaortic. So in a perimembranous VSD, you can have a prolapse of the non-coronary or the right coronary cusp, or even more commonly, in a subpulmonic VSD, the right coronary cusp almost invariably prolapses into it. Those who develop an actual aortic regurgitation are fewer, that is only 6%. So aortic regurgitation is particularly common in a subpulmonic VSD. It may also occur in a perimembranous VSD. Much of the information that we have on the clinical behavior of cardiac lesions, we owe to the legendary cardiologist of the 1940s and 50s and 60s, Paul Wood. In his historic series, he had noted that irreversible pulmonary vascular disease has happened in infancy in about 4/5 of the children that he saw with Eisenmenger later. The point is, if you miss a large VSD in infancy, quite often they become inoperable. A small VSD has a chance of infective endocarditis. This is like 1.3 per 1,000 patient years. Now, how do you clinically evaluate a VSD? Obviously, this is your important first step in the assessment of a patient. The clinical findings, along with the chest X-ray and ECG, can often predict the echo findings. I'll come to this a little later in some detail. To highlight the fact that clinical evaluation would give you important direction in interpreting echo and hemodynamic data. And you must also know that saying that a VSD is small doesn't necessarily mean that it does not require closure. There are selected circumstances where you may recommend closure for a small VSD also. So how does a large VSD present? Features of heart failure, feeding difficulty and a suck, rest, suck cycle are features of heart failure in infancy. We have discussed this in one of the opening lectures. Babies tend to have tachypnea. This is because the overloaded lung, the volume overloaded lung tends to have some transudation into the interstitium, and a greater respiratory effort is needed in moving them. So features of cardiac failure would manifest as feeding difficulties and tachypnea. They may also get recurrent respiratory tract infection. Remember, recurrent respiratory infection is more likely to occur in a VSD or a PDA or an AV canal rather than in an ASD. Failure to thrive is very common because they don't take enough calories because the feeding is poor. And the congested, when there is right heart failure as well, the congested GI mucosa is not conducive to good absorption. Catabolism is increased in heart failure. They tend to have recurrent pneumonia. Plus, you know that VSD could be part of different syndromes. So these syndromes may independently affect the growth of the patient. This image, which I borrowed from Dr. Krishna Kumar, is the poster child of VSD in a developing country anywhere in the world. This is a baby with a large VSD and ASD who had a birth weight of 3 kg plus, but who weighs 2.5 kg at 6 months, showing what happens when there is a large VSD and the consequent malnutrition. So when you examine the child in your usual pediatric pattern, please do look for any dysmorphic or syndromic features. You know that VSD occurs as part of a number of syndromes, including Down syndrome, but many others can have a VSD going along with it. I will not go into it today. Signs of heart failure are evident on general examination like tachycardia, tachypnea, cardiomegaly, and hepatomegaly. Precordial activity is increased. You can feel that the apex beat is displaced down and out. On auscultation, the first sound is normal. The second sound is closely split or single because in a large VSD, both the ventricles are pumping against almost similar resistance, the pulmonary vascular being a little lower. On the other hand, in a small VSD, the murmur is louder, I'll come to it, and the second sound is widely split. In a small VSD, there is shunt through the VSD all through systole. all through systole, the RV pressure is lower than the LV pressure. So there is a pan-systolic murmur, maybe associated with a thrill. This used to be called the malady de Roger, a small VSD with a loud murmur. In the in the larger VSD, on clinical examination, it's a short early systolic murmur. Sorry for the wrong typo there. It is a short early systolic murmur because in a large VSD also, as the LV starts pumping, there is a short period in systole when the LV pressure is higher than the RV. But then it quickly equilibrates. So the murmur is heard only in that part, even though the shunt itself continues all through systole, but at a similar pressure. The murmur is generally a early systolic murmur. You may hear a third sound over the apex beat. You may hear a mid-diastolic murmur across the mitral valve because there is an increased flow there. There's a different named VSD called a Gerbode defect. Now, if you look at the anatomy of the ventricular septum, remember the mitral valve is inserted into the septum higher than the tricuspid valve. So this portion of the ventricular septum is actually between the LV and the RA. So you could get a defect there, and if that happens, the shunt will occur from LV into RA. Even that defect is small, but it can cause heart failure because it is RA, a low pressure chamber, which is receiving this shunt at systemic pressure. So this baby would present with a loud murmur, elevated JVP or hepatomegaly, cardiomegaly with RA enlargement in chest X-ray. This is an exception to the rule that a small VSD with a loud murmur ordinarily is not a cause for heart failure, but a Gerbode VSD could be a cause for heart failure. In fact, more common than the classical or type 1 Gerbode defect, there is a more common type 2 or indirect type of Gerbode defect because you may have a defect here, which is a typical perimembranous defect, and you may have a hole in the tricuspid valve septal leaflet. And this results in, or some abnormality of the septal leaflet of the tricuspid valve, which allows that left to right shunt from the LV to RV to be directed into the RA. This will be called an indirect Gerbode. That's all about the clinical findings. Now, when you do an ECG, remember in a small VSD, ECG may be normal. But if there is a significant left to right shunt, what happens is that the LV and LA gets enlarged. So you will get LVH. LVH will be manifested as tall R waves in V5, V6. Since this is related to a volume overload, deep Q, a Q which is deeper than 3 millimeter, appears in V5, V6. So this is the feature of a moderately large VSD. And LA enlargement may be manifested as a terminal negativity of P in V1. But in the real large VSD, you get a characteristic appearance which has been referred to as Katz-Wachtell phenomenon. I've illustrated. This is because you have a biphasic complex in V2, V3, V4, one or more of these leads, the combined voltage of which is more than 45 millimeters. So there's a very tall R and a very tall S, denoting biventricular hypertrophy in an infant. This is called Katz-Wachtell pattern. RVH with right axis deviation and absence of prominent LV forces is seen when the VSD is turning into Eisenmenger. If the shunt has gone away and the high PVR is the deciding clinical factor, what you would see is RVH with right axis deviation and less of LV. Look at this ECG. Here, axis is normal. If you find we are lead 1, 2, 3, everything is positive. So axis is normal. You don't actually see an LA enlargement here. But if you can see the V4, look at the height of R wave. 1, 2, 3, 4, 5, 6, 7. It's 35 millimeter. And down also, it is almost as much. So 70 millimeters is the combined voltage of R plus S in V4. More than 45 is Katz-Wastel phenomenon. So this is illustrating biventricular hypertrophy in an infant with a large VSD. The other thing that you would see is chest X-ray. It will show an enlarged cardiac silhouette. The main pulmonary artery is prominent. The RPA and the LPA are dilated. And you find that the pulmonary vascular markings extend to the lateral 1/3 of the lung fields. You say then that there is increased pulmonary blood flow. So this is what you should be looking for in an X-ray. Like the, I'll come to the, show you an X-ray in a second. Just highlighting the points to remember. If the VSD is small, you can expect a normal X-ray. Cardiomegaly, increased pulmonary vascularity, and prominent main pulmonary artery segment denotes that there is a significant left to right shunt. And the degree of cardiomegaly correlates well with the degree of left to right shunt. A large VSD with large shunt will have a big heart. And those with a large VSD and elevated pulmonary vascular resistance will show that there is no cardiomegaly. MPA is prominent, RPA, LPA are prominent, but the pulmonary vascularity is decreased in the outer third of the lung fields. We will illustrate this shortly. If you see this X-ray, what do you see here? There is obviously a cardiomegaly. This is cardiomegaly. The main pulmonary artery is enlarged. That is why this convexity is there. The left pulmonary artery can be seen through the cardiac silhouette. It is unlikely that you will see it, but look at the right pulmonary artery. The right pulmonary artery is dilated, and you can see the markings coming all the way to the periphery. So this illustrates all the points that we said: cardiomegaly, main pulmonary artery, dilated central pulmonary artery, that is RPA in this case, and increased lung field vascularity. Now we can move to echo. But before you move to echo, remember, if your baby was in heart failure, the baby has to have a significant size VSD. If the baby had an unimpressive murmur with heart failure, or rather an early systolic murmur, that murmur denotes a large VSD. Your X-ray would tell you if the heart is enlarged and the vascularity is increased, you are dealing with a large shunt. These factors should be borne in mind when you are looking at the echo and interpreting that information. So some of the common features in echo would be an enlarged LV and LA if the shunt is significant. In echo, we have the advantage of seeing a Doppler gradient. We can see the Doppler gradient across the VSD, which will predict the RV pressure. In a large defect, this gradient is not there or is less than 20. A gradient of say more than 60 or 70 tells you that you are dealing with a small VSD. You may have valvular problems. The dilated LV or an associated mitral valve abnormality may cause mitral regurgitation. Similarly, tricuspid regurgitation is common, and aortic regurgitation could occur either due to an inherent abnormality of the aortic valve or more often due to prolapse of the coronary cusp. MPA and branches would be dilated, and which views? Every view has something to tell you regarding a VSD. Now, this is a perimembranous VSD. Remember, a perimembranous VSD is a subaortic one. Here you can just see the beginning of the aorta, and the defect is below that. You see the flow from the LV to the RV. This LV is dilated. This LA is dilated. Actually, the pulmonary venous return that is coming into the LA, this flow is the pulmonary venous return that is rather brisk. Now, this is showing a small subaortic VSD. You'll see the color flow image later. This is the LV. This is the RV. This is where the VSD is. This is to show its relation to the aortic valve. Here is the aortic valve. Here is the VSD. And see the flow through that. This turbulent flow. Whenever you get a mosaic color, we say that the flow is turbulent. And there's a bit of TR because you find the turbulence coming into the RA as well. So this is a perimembranous VSD. We call it a posterior perimembranous VSD because it's there in the posterior part of the septum. We often use the word septal aneurysm because the the septal leaflet of the tricuspid valve tends to get stuck to the margins of the VSD. So this is an effort on the part of the heart to reduce the VSD. In fact, a common mechanism by which a perimembranous VSD decreases in size is by the adherence of the septal leaflet forming an aneurysm of the membranous septum. You call it an aneurysm of the membranous septum because in systole it will bulge into the RV. This is again another small posterior perimembranous VSD. There is a touch of tricuspid regurgitation. We refer to an inlet VSD. Remember, an inlet VSD is the one which is seen when both AV valves are seen. Here, this is the mitral valve opening. This is the tricuspid valve opening, and you find a huge defect here. This is a huge defect, and it's a large inlet VSD. In a tetralogy of Fallot, we have a malaligned VSD. It's a conoventricular VSD because it involves the conus or the outflow part, and it also involves the perimembranous septum. But the word conoventricular is synonymous to perimembranous. So this is just called a perimembranous VSD with malalignment. It is still right. If you look at a case scenario, the typical way in which a large VSD presents to you, you're seeing a 4-month-old baby in your OPD. The birth weight was 3.1. Weight is increased now, it is 4.2. But there is a history of feeding difficulty and tachypnea. On examination, you find that the heart is enlarged. The second sound is closely split. The P2 is loud. There is a grade 2 early systolic murmur at the left sternal border. There's a mid-diastolic murmur over the apex beat. And on echo, if you see here, this is the dilated pulmonary artery, this is the RA, this is the RV, and this is where the VSD is. This is typical of a perimembranous VSD extending to the outlet. In some of the large VSDs, one of the ventricles may be small, so that we call it a functionally a single ventricle. Like in this case, you find that the RV on this side is very small, the LV is larger, and there is a large inlet VSD. So here this large VSD has amounted to a single ventricle. So you're seeing different flavors of the theme of ventricular septal defect. The typical tetralogy VSD, a conoventricular or a malaligned VSD. This is the aorta. See that the aorta is committed to both the ventricles. There is a left to right shunt here. There is no obstruction. It's not unusual for these malaligned VSDs to actually present with heart failure and merit VSD closure. They don't necessarily evolve into tetralogy. This is a mid-muscular VSD. We refer to muscular VSDs also, remember. So this is the tricuspid valve. This is the mitral valve. So somewhere in the middle of the septum, you can see this abnormal color flow. So that is a mid-muscular VSD. You may occasionally do a cardiac cath in cases of a large VSD. This is indicated in borderline cases when a definite decision cannot be made regarding operability after a good history, examination, and non-invasive investigation. The problem is common in countries like ours because you find a 10-year-old child with a large VSD, some evidence of a left to right shunt. Statistics tells you that at the age of 10 years, it is more likely that this child will be inoperable. But you look for subtle signs of increased shunt, but you need a little more definitive data to send the child to surgery. And that is an indication for a cardiac catheterization. Also, today, some VSDs, notably muscular VSD, occasionally perimembranous VSD, you can close it transcatheter, and a cardiac catheterization is part of preparing the baby for the transcatheter closure. And this right heart catheterization is the gold standard to assess hemodynamic parameters and vasoreactivity in babies with large VSD. All that we mean is older children, large VSD may require cath, but very important to use your clinical parameters before you rely on the cath data. And these are the circumstances when a cath is done. When you do a cath, you calculate the shunt. This is done from the oximetry samples that you take from different areas like the vena cava, the pulmonary artery, the aorta, and the pulmonary vein. Based on this, you can calculate how much is the pulmonary flow as against the systemic flow. You call it QP by QS. QP denoting the pulmonary flow and QS denoting the systemic flow. Sometimes in older children, we want to see when the operability is borderline, you see the response to oxygen or to nitric oxide to see whether it is responding to vasodilators and to consider whether surgery is possible at all. When you do this, the question that you're trying to answer, there are empiric thresholds that have been laid down to say that beyond this value, surgery is unlikely to have a favorable outcome. As I said, the clinical assessment with the echo and the ECG are very important, but taken along with that, oxygen saturation and pressure measurements do help you in taking a decision on operability in borderline cases. And let's look at a typical inoperable patient. This is a 10-year-old boy. He has no cardiac symptoms. Typically, what could happen is that the mother might tell you, oh, this child used to get recurrent chest infection and he was on digoxin and diuretics when he was 3 months and 6 months. But by the time he was a year and a half, he did not require any medicines and he started putting on weight and he has been doing well ever since. A very alarming history. When you examine, you find that there is no cardiomegaly. The second sound is single, and there may be a constant pulmonary ejection, like from the dilated pulmonary artery. Very characteristically, there is no murmur. And this is the X-ray of the inoperable patient. Remember, in the operable patient, we saw cardiomegaly, dilated pulmonary arteries, and increased peripheral vascularity. Whereas here, definitely there is no cardiomegaly, but the main pulmonary artery is quite prominent. The right pulmonary artery is dilated. But if this right pulmonary artery is this big at the hilum, why is it not dilated down below? This is what is called pruning. Just as you prune a plant, nature has pruned this pulmonary artery. This is the sign of development of pulmonary vascular disease. So there is no flow increase to the lower part. So the pulmonary artery looks as if it has been suddenly cut into a smaller size. So this is a pruned, dilated right pulmonary artery. So no cardiomegaly, dilated main pulmonary artery, dilated RPA which is pruned, and no increase in the peripheral vascularity. These are features of the inoperable VSD. If you look at the ECG of the inoperable VSD, remember what did we see in the operable VSD in an infant? We found a Katz-Wachtel phenomenon. Here, on the other hand, if you see, the axis is obviously right. See, lead 1 is negative, lead 2 is negative, lead 3 is positive. So this, in fact, AVR is equiphasic. So that tells you that the axis is like plus 120. And if you look at V1, you have a tall monophasic R. And if you look at V6, you have a deep S. So the characteristic finding here is RVH, and you don't find any Q waves in V5, V6. This ECG is very bad when you're assessing operability. This ECG is not good for the patient. Isolated right ventricular hypertrophy with right axis deviation, no evidence of LV forces. Patient is unlikely to be operable. This patient's cath data, the patient had very high pulmonary vascular resistance. I told you more than 6 is considered inoperable. So here there was a 14.1 and again a wrong typo there. After 100% oxygen, it had dropped only to 11. And the PA diastolic pressures, which denote the pulmonary vascular resistance very well, they were systemic all through. It did not improve with oxygen. So this type of cath data will go with that X-ray and will tell you that the patient is inoperable. And what happens to the inoperable VSD? You call it Eisenmenger syndrome. Eisenmenger syndrome in VSD is a large VSD with right to left shunt because of elevated pulmonary vascular resistance. The word Eisenmenger syndrome is non-specific. It can occur from any large previous left to right shunt over a period of time. It can develop right to left shunt. But when you say Eisenmenger VSD, the the problem has happened in infancy or by 2 years of age, and since there has been an irreversible PAH. So it's a large VSD, irreversible PAH, right to left shunt, the absolute reason why we need to operate in early infancy. And classically, as we mentioned earlier, a previously asymptomatic baby becomes a previously symptomatic baby becomes asymptomatic. That is very ominous. This may mislead the parents as well as the pediatricians that the child is doing well. It's very important to have a proper cardiac evaluation, not necessarily by a pediatric cardiologist. If you are looking at the X-ray, if you are looking at the baby clinically, you can draw this conclusion that if your second sound is loud, your X-ray shows that a previously large heart is decreasing in size, but with a dilated main pulmonary artery and branch pulmonary arteries. That is development of PAH. If you're looking for overt cyanosis, it's usually not there in pediatric age group. It usually not evident till third decade or so, and they even have good effort tolerance. So that is why by all yardsticks in clinical judgment, they seem to have improved. And effort dyspnea, cyanosis, arrhythmias, particularly atrial flutter, and congestive heart failure are evident by third or fourth decade. Death occurs in fourth or fifth decade, and the death may be related to a hemoptysis, it may be related to a syncope, it may be related to arrhythmia, it may be a gradual slipping away due to right heart failure. These are all the outcomes that await patients with Eisenmenger syndrome. Today, careful medical therapy, including targeted pulmonary arterial hypertension therapy, can improve quality of life and prolong survival to the fifth decade or beyond in a VSD with Eisenmenger syndrome. So Eisenmenger VSD is not all that bad. There is a way of managing it, but it is our duty to prevent a large VSD from going into Eisenmenger syndrome. Thank you. I'll be very happy to answer any questions. You could ask questions either by chatting or by actually asking questions. Please go ahead. If you don't have any question, I'm going to conclude. Oh, from SAT, there's a question as to ideal timing of surgery. I would say around 3 months. If you're following up a baby from newborn period, we would rather operate around 3 months of age. 3 to 6 months in any case. And if the baby is in heart failure at 2 months, we would operate at 2 months. The earliest that I have sent a large VSD for surgery for heart failure is 1 month of age. That baby has done very well. So the point is, by 3 months, you can expect that the baby will be in manifest heart failure. If it is not in manifest heart failure, it is an unduly elevated PVR, which is even worse. So we need to operate around 3 months of age. Because of practical reasons, we would say between 3 and 6 months. But depending on the symptomatic status, closer to 3 months if the baby is in obvious heart failure, and definitely earlier than 6 months. Any other question?
Uh, Sir, WNC Thaikard has a question.
How long maximum can we keep the patient without surgery?
Oh, I'm afraid I can't hear you. Either somebody can
How long?
relate or you can type it for me.
All right. Thank you. How long maximum we can keep the patient without surgery in the VSD?
See, there is a fundamental question there. Should you wait? What is the logic of waiting? The In the case of a defect which is causing heart failure, the earlier you operate, the better. But since you asked the question how long you can wait, since Gerboday VSD is a smaller defect, the patient ordinarily does not develop pulmonary hypertension. So even at 5 years, we can operate for a Gerboday defect, but they will go into heart failure. There are some Gerboday defect where the amount of heart failure is minor, which is allowing the patients to survive without a major problem into a later age like 5 years or 10 years. But once you have diagnosed a Gerboday defect and the baby has clinical heart failure, you shouldn't wait. I can sort of ensure that I see the question. When you talk, you're not necessarily audible to me. Any other question? If you don't have any questions, I'm going to wind up.
Any other questions?
Question ഉണ്ട് SAT.
Okay.
Welcome, SAT.
So can you please explain about Gerboday defect?
Sure. I think I'll go back to my picture. We just see that. It's very important to understand the anatomy of the atrioventricular septum in understanding the concept of Gerboday defect. The important thing is, sorry, just 1 second, I'm getting you that image. Please look at this picture. You have the two atria above, the two ventricles below. It's an important part of cardiac anatomy that the mitral valve septal leaflet is inserted into the septum at a higher point compared to the tricuspid valve. Mitral valve is higher, the tricuspid valve is lower. This is so relevant in anatomy that what we call the left ventricle is the ventricle which has a septal leaflet which is inserted higher. This is important in anatomic differentiation. So this arrangement of the two septal leaflets, one being higher than the other, allows a portion of the ventricular septum to actually fall between the left ventricle and the right atrium. That is what this arrow shows. Between the left ventricle and the right atrium, there is a portion of the septum. So if there is a hole in that septum, the shunt occurs from the LV to the RA. This actually is uncommon. A true defect in the true atrioventricular septum is uncommon. But this is called the direct Gerboday defect. There is an indirect Gerboday defect. After all, the defining feature of Gerboday is a VSD which is getting into the RA. That can also happen with a regular perimembranous defect which will occur here, not in the atrioventricular septum, but below the septal leaflet of the tricuspid valve. Remember, The septal leaflet of the tricuspid valve has a habit of getting stuck to the septum. So when you have a VSD here, this VSD may shunt into the RA. That is called an indirect Gerbode defect. So these are the two types of Gerbode defects. And these defects are generally not large. After all, the atrioventricular septum is a smaller portion of the septum. Therefore, pulmonary hypertension is not the problem. But the RA, which is a low resistance chamber, is not supposed to receive blood flow at systemic pressure from the left ventricle. That is what pushes this baby into a heart failure. And I had mentioned that heart failure and a loud murmur ordinarily do not go together. Because in a VSD, when heart failure occurs, the VSD is large and the murmur tends to be short. But not so for Gerbode. For Gerbode, even though the murmur is loud, there is clinical heart failure because the shunt is occurring into the RA. Is that clear? Is prophylaxis indicated for infected endocarditis below 1 year? Good point. For a small VSD, it is better to give prophylaxis. But the point is the circumstances where infective endocarditis prophylaxis is required below the age of 1 year are very few. But if a baby is undergoing a major genitourinary procedure, the baby has a small VSD, you may not have otherwise given an endocarditis prophylaxis, but you should definitely give prophylaxis if the baby has a cardiac lesion, including a small VSD. How to follow up a small VSD? Clinically look for a murmur. You can do an echo maybe in a year. Say like American guidelines will be to do it in 5 years because somebody needs to pay for it and they don't want to do it. But following up a small VSD with an echo once in 1 or 2 years is quite fine. And there's a question on the ways to confirm reversibility of pulmonary hypertension. It's a little core cardiology, but I would answer that. In any pulmonary hypertension, clinically, if you are finding that there is a mild cardiomegaly, that X-ray shows a mild increase in vascularity, the echo shows that there is a mild increase in LALV. Why am I keeping on saying mild? If there is a large increase, there is no question of difficulty in saying operability. Where you have a genuine difficulty in speaking of operability, a subtle increase in the LALV size is an important marker. And in the cath lab, when you find that the pulmonary artery diastolic pressure is lower than the systemic diastolic pressure, that the pulmonary vascular resistance is lower than 6 Wood units, and in response to oxygen, if this was elevated, it drops below 6, and the pulmonary artery diastolic pressure is clearly below the systemic diastolic pressure. These are the ways of establishing reversibility of pulmonary arterial hypertension. As I said, it's a little core cardiology. Whether you would be interested in that core cardiology, I'm not certain. Any other question?
Any other questions or clarifications?
Otherwise, we'll wind up.
Okay, sir. Thank you
Okay.
for the wonderful class.
Thank you, everyone. Have a good day.
Thank you all for joining.